Okay, welcome everyone. My name is Brianna Botsford and my pronouns are she and her. I'm a proud supporter of the Lois Hole Hospital Women's Society, and I'm a member of the Supporter Experience Committee. And for those of you who don't know, the Lois Hole Hospital Women's Society is an organization of people in all ages and stages of life, passionate about women's health and excellence in healthcare and treatment. The Society raises awareness for and important funds for a variety of initiatives at the Lois Hole Hospital for Women. Hopefully you got to see some of those on the slide as you were joining us this evening. And we host these Mind and Body Talks as an inclusive speaker series to engage and stay connected with our community. Big thank you to Alberta Blue Cross for their continuous support that allows us to run this informative series. And please welcome Marianne from Alberta Blue Cross as she will do a land acknowledgement. Thank you, Marianne. Sorry, just bear with us for a quick moment. Marianne, yay, perfect. Sorry for the difficulties.
No worries. So I'm Marianne. My pronouns are she, her, and I'm with Alberta Blue Cross in Community Impact. And we're really excited to be here today sponsoring this event. So I'll just do a land acknowledgement. And so today and every day, we respectfully acknowledge that we are on the traditional lands referred to as Treaty 6 territory. We recognize that the City of Edmonton and us, the people here, are the beneficiaries of this peace and friendship treaty. Treaty 6 encompasses the traditional territories of numerous Western Canada First Nations, such as the Cree, Saulteaux, Blackfoot, Métis, Dene, and Dakota Sioux. We're taking this important moment here today to acknowledge all of the many First Nations, Métis, and Inuit people whose footprints have marked these lands for centuries. Now, I'll send it back to you, Brianna.
Thank you, Marianne. Now, we'll just go through a couple housekeeping items and I'll provide a little bit of an overview of the evening. So tonight we are honored to have our guest speaker, Associate Clinical Professor and Senior Medical Physicist in the Department of Oncology at the Cross Cancer Institute. We are hoping that you will come away from this presentation feeling educated about all the ways to understand and protect you against a disease that affects a number of women. So this is a safe place for all to come and have their questions answered. If you have a question for our speaker, please type it in the chat box and we will read it at our Q&A session at the conclusion of the presentation. This lecture is being recorded and will be posted on the Women's Society YouTube channel tomorrow. We are using the Zoom webinar feature, so each of the panelists will appear as they speak, but you don't need to worry about your own video being displayed. We hope that you enjoy this viewing experience. We are also using the live transcript function. So if you would like to see the available transcript, you can enable this feature on your computer or device. There will be a brief survey emailed following this lecture. As we always love your feedback, and we try our best to incorporate it when we are planning and developing these sessions. Everyone who fills the survey out gets entered into a draw to win a $25 gift card courtesy of Alberta Blue Cross. So now, without further ado, I'm going to present our amazing speaker, Dr. Geetha Menon. She is an Associate Clinical Professor and Senior Medical Physicist in the Department of Oncology at the Cross Cancer Institute, University of Alberta in Edmonton. She is also a proud member of the Women and Children's Health Research Institute. Dr. Menon received her PhD from the University of Alberta and holds a fellowship in the Canadian College of Physicists in Medicine. Over the years, her clinical areas of interest and expertise has been in brachytherapy and women's cancers, mainly breast and cervix. Her principal research focus has been in MRI-based gynecological brachytherapy, dosimetry in ocular and prostate brachytherapy, and use of machine learning in radiation oncology, which have resulted in innovative research spurred by observations from clinical practice. Dr. Menon has received several grants to fund her research, and the multidisciplinary partnerships have resulted in several peer-reviewed journal publications. Please welcome Dr. Menon.
Can I share my screen now?
Absolutely.
You see my screen? Okay. So good evening, everyone, and thank you so much for coming to this session on a cold evening. I'd really thank the organizers who are listed here and the Blue Cross for having me and giving me this opportunity to present on some of the innovative research that we are performing at our own local Cross Cancer Institute by a wonderful team of multidisciplinary researchers. I'd like to do my own land acknowledgement, acknowledge that I'm really privileged to live in Edmonton and be part of the University of Alberta, situated on the Treaty 6 territory, the traditional lands of the First Nations, the Métis, the Inuit, and all the First Peoples of Canada, whose presence continues to enrich our vibrant community. So here is what's coming in the next 40 to 45 minutes. We will look at what cervical cancer is, what the disease is, and what are the risk factors, and what are the different types of cervical cancer. But my focus is going to be on locally advanced cervical cancer. We will, I'll tell you what it is later on. And then what are the state-of-art treatment options for this, especially for locally advanced cervical cancer. You know that as of now, like, it's not a one-size-fits-all treatment. It does not help that kind of treatment, because if you want good outcomes for patients, you have to really personalize your treatment. And that's where our research activities have been focused on. So I'll give you a brief overview of what activities in research to help patients are happening at the Cross. And finally, we'll also discuss how you can help us do better. So a major portion of this talk will be about the research and our goals for achieving these goals. And we have ties with several local groups, national and international. We'll talk about that too. So many of you must be wondering, who's a medical physicist and why is she giving a talk on cervical cancer? So in a nutshell, you know that when patients are treated with radiation, it has to be really precise the way it's delivered, and very crucial how it is delivered. So in one sentence, as we define it, a medical physicist is somebody who assures safe and effective delivery of radiation to achieve a diagnostic or therapeutic result as prescribed in patient care. Now, what does this really mean? We work with physicians. There are a lot of radiation therapists who actually deliver the treatment. Then we have groups called dosimetrists who really plan those treatments for delivery, engineers. So together, what we basically do is we ensure that the radiation that's delivered to a patient is from a machine that works properly, or all equipment that's used for the delivery is calibrated properly. That is, when you say that this is the amount of radiation you want to be given, it exactly delivers that. And we look at all the types of planning that needs to be done for delivering that radiation. So I hope that makes it clear. And my research interests have been, as it was said in the introduction, and thanks for the introduction, is mainly on women's cancers, mostly breast and gynecological. Have a great interest in ocular melanoma brachytherapy also. And a lot of our gynecological treatments have been funded by WICRI, the Women and Children's Health Research Institute, and the Alberta Women's Health Foundation, AWHF. Thank you so much for that. So when a physicist gives a talk, you are wondering, is there going to be any rhyme or reason? So I'll make sure I touch on both. And having said this, I have a disclosure to make. I'm not a physician, so I'm not an expert on the clinical characteristics or particulars of cervical cancer, but we'll give you a good overview of the radiation delivery side of these treatments. So what is cervical cancer and what are the characteristics? So shown on the left here is a normal cervix. There is a uterus and the vagina here. Now, when there are cancer cells there, here, you can see it here, that's an early stage. These cancer cells, if they are caught early through screening or even before that, like if there is a potential for that, you can really have good cure for that. After that, what's going to happen is that the cancer is slowly going to spread outside the cervix and into other areas of the body, and that we call metastasis. That is, the tumor has metastasized outside where it was produced. So what physicians usually do is there's something called staging of these cancers. They will look at different ways, like how much of this cancer is present in locally and how much has it spread. And based on all those decisions or their experience of looking at it, they will decide what kind of treatment is this patient going to have. So I think all of us know the best way to treat these cancers is to do surgical resection. And in a case of a uterine or cervical cancer, it would be hysterectomy, where you're going to remove the uterus and a part of the cervix. But depending on the type of the cancer you have for the cervix and the characteristics of the cancer, surgery may not be the best option. In that case, we're going to have another path of treatment, and we're going to talk about that in this lecture, and I'm going to call that locally advanced cervical cancer. Now, what are the risks associated with this? HPV infection, or the human papillomavirus infection, is the main contributor to cervical cancer. But by itself, it's not a huge factor. There are a lot of cofactors that's associated with it. One would be sexual activity, like multiple partners, having sex at a young stage. Another one is smoking, or having a weakened immune system. When you have a weakened immune system, like infection to human, like the HIV, when your system is weak, there are more chances for you to contract HPV, right? Taking drugs to suppress your immune response. Or if there is a history of sexually transmitted infections. And finally, there could be other reproductive factors like taking oral contraceptives or multiparity, that's having several children. And there are other factors too, but these are some of the main risk factors associated with cervical cancer. Now, there are different types of cervical cancer. So shown here is the two main types, which would be squamous cell carcinoma and adenocarcinoma. And squamous cell carcinoma contributes to about 80 to 90% of patients. I mean, the number is going to change if you look at different literature, but mainly it's going to be squamous cell carcinoma. About 10% is adenocarcinoma, and the rest are like about 5% is going to be adenosquamous, which is a combination, and several others. But they're very small quantity. Like if you look at the whole, all the number of patients that we teach or treat. So where does squamous cell carcinoma occur? It occurs in the exocervix, which is actually the outside of the cervix, and then you have the adenocarcinoma happening at the entrance into the uterine canal, and that's where you have some glandular cells, and that causes adenocarcinoma. Now coming to, so with this kind of information, we're going to go into how these are treated. So like I said, this is my knowledge on this one. Now let's go to where I work mostly with, and that's would be the treatment part. And so when a patient who has a locally advanced cervical cancer comes here, they are first diagnosed to find out how much disease they have. So usually we use 3 modalities for finding what to diagnose how much is the extent of the cancer. We use a CT, MRI, or positron emission tomography, or PET. You know it as PET. So if you look at all these images, you can see that MRI has really good contrast. That means you can really see the tumor and the surrounding tissue, because MRI's best feature is that it can show soft tissues really well. So after having a decision on the treatment path, the way these patients are treated is mainly by 3 modalities. One is chemotherapy, next is external beam radiotherapy, and then finally brachytherapy. We'll look at what each of them are. I work mostly with external beam radiotherapy and brachytherapy. The chemotherapy is dealt with, not the radiation department, it's the medical oncology department. And what is chemotherapy? You probably know that it's usually drugs that are injected to kill the tumor cells. In cervical cancer, the main aim of these of chemotherapy is to work as a radiosensitizer. And what that means is that you're going to treat this patient with radiation, right? So it actually increases the potential of that radiation to kill the cancer cells. So the patients, so here's a schematic to help you understand the pathway. The patients usually have 5 weeks of treatment. They have treatments every day over the 5 weeks. That is, they have 25 fractions of treatment that's shown here. And at every week, they have 1 cycle of chemotherapy. So the chemotherapy actually sensitizes the effect of the radiation. So the external beam radiation typically takes about 5 minutes to deliver, but it takes about 15 minutes to set up the patient in the right position and deliver the radiation. And then after week 5 comes brachytherapy. I'm not going to go into details right now. We'll do that after a couple of slides. The goal here is to deliver all this treatment, starting from the first day of EBRT to the end of brachytherapy within 50 days. And that's shown as a factor to affect the cure of the patient, or for better outcomes. 50-day rule is followed here. And most of our patients do meet that goal. So let's look at what are each of these radiation. So first of all, external beam radiotherapy. So as the word suggests, external beam means the radiation is coming from outside the body into the body and treating it, right? So before I start, we have to tell you about a couple of milestones that led into this treatment option. So one of them is Wilhelm Röntgen, his discovery of X-rays in 1885. So he was one of the pioneers in this field of treatment, if you want to think about it. The other is Henry Becquerel, his discovery of radioactivity in 1896, another milestone in cancer treatment using radiation. And if you, like in the early 30s and 40s, people had no clue how to use radiation, right? So there was lots of misuse. And it said like in somewhere around 1930s, if you went to buy shoes in certain stores, they would do your x-ray for free of your leg to show you how your bones looked. No clue at that time, right? And a lot of bad effects because of that. Oh, and shown here is a picture of Rankin's wife's hand, which shows the wedding ring also on it. So two discoveries in history that was accidental, but really medical miracles that helped treat cancer later on. So the first cancer treatment that happened using an external beam machine happened in Canada. And it was a machine that was designed by Dr. Harold Jones. And the first treatment happened like days apart in 1951, one in the University of Saskatchewan and the other one at the Victoria Hospital in London, Ontario. So it was called the cobalt bomb. And why was it? Because it treated using the cobalt radiation. And it was like as if you were like putting in a bomb where the cancer cells are. So in those days, it was called a cobalt bomb, and it was a leading innovation at that time. Dr. John's student, Dr. Cunningham, we consider them parents of medical physics, after his retirement, used to live in Camrose and come to the Cross to teach us. So we were all students. We're all privileged to be students of Dr. Cunningham. Now, of course, things kept evolving, right? Technology keeps on evolving. In 1953, the first linear accelerator-based radiation therapy for cancer began in London. But you know what? In these cases, like if you really don't sculpt the dose or like tailor the dose to the tumor, a lot of the organs around it are going to get treated too. So here is shown like the bladder, and then you have the rectum at the bottom, and you really only want to treat the cervix in the middle, but so much of the green part shows the dose that's being delivered. You don't want that. You want something like here, where the blue, which is the bladder, and the brown, which is the rectum, is totally spared, and your radiation is just given where the tumor is, where that's shown in green here. So that's where our modern treatment machines come into play. So at the cross, we have the latest techniques to deliver radiation. We have 8 of these modern linear accelerators, or we call them the LINACs for short. They produce very high energy X-rays to treat the tumor. The advantage of this is that you can give large areas. You can decide on how much area you want to treat or how much volume you want to treat. And these high energy X-rays are going to be targeted at the tumor. Some patients say that they felt like when they lie on this couch, they feel like they are in space with a robot, like a rocket around them. This is a very fancy machine. You can see that it can rotate around the patient and while delivering the radiation. Now, you don't want a square beam to follow on the patient. You really want a very like a conformal, that's the word we use, tailored to deliver the radiation. And you can see it's done using leaves here, and these leaves actually intertwine. They play with each other and conform to the shape of the tumor while delivering the radiation. So if this is the scan of a patient, and if you really want to treat the pelvic area, you can design it using something what we call the planning system. And we have fantastic dosimetrists who are very educated and knowledgeable in how to plan these treatments and deliver this high energy of radiation to treat it. So what is the path that a patient follows? So first of all, the patient would have a CT scan, get the scan. And this is, I'm just going to concentrate on cervical cancer. After that, what's going to happen is that the doctor is going to come and we use the word contour, but basically what they're doing is they are drawing or identifying or segmenting where the tumor is. Here it's shown in the pink. then there is the other organs around it, because you don't want to cure the tumor, but by giving enough radiation, but at the same time kill all the normal cells or the tissues around it. The patient's not going to have a good life after that, right? So you want to really save all the normal tissue around it. So once that has been identified, a plan is put, a treatment plan is put using algorithms that have been developed and dedicated system, which will put the dose where it needs to go. So in this plan, you can see that the green area is where the dose is going to go. And then you can see it's usually given in a circular manner. So the gantry is going to rotate around the patient. Gantry means the head of the machine, okay? And deliver the tumor. And once the patient goes for treatment, we take verification of images so that the patient is placed exactly where we want the radiation to target the tumor, and the patient gets their treatment. So once this is delivered, okay, now the question is then what happens? So like I said, the patient's going to have 5 days per week of treatment for 25 visits for 5 weeks. See how well this is where the tumor was before the treatment, and see how it has shrunk after the treatment. And this is after an EBRT or an external beam treatment. But that's not enough, right? You still want to cure that extra tumor that is left in the patient. So what do we do now? So to do that, what we use is something more. You want to give more dose to that region. Oh, I forgot to say what dose is. So when you go to let's say when you go to a physician with a cold or a cough, you get prescribed a drug. But in radiation therapy, what you get prescribed is radiation. And how do you measure that radiation? That radiation is actually some energy that is being deposited in the tumor, and it's killing that tumor. And that required amount of energy is what we call dose. And so for every tumor site, it's going to be a different dose that will be prescribed. And the way it is prescribed is going to be different. We have values for the tolerances for the different good tissue that's around it, or the healthy tissues. So we don't want the dose to be more than your tolerance value, because then your normal tissues are going to be damaged. So now our aim is to give more dose to the once to that remnant tumor that is there. So how do we do that? So to do that, we cannot give more external beam. The reason is because then you're going to go beyond the tolerance of your normal tissue. So you can't. So the best thing to do would be to treat right where the tumor is. So something like putting some radiation source right where the tumor is. And that's where brachytherapy comes into play. Brachy in Greek means short distance. So brachytherapy is where you're going to put the radiation where the tumor is, shown in the yellow part here. It's going to act as a dose booster, or you can think of an enhancer that's going to kill the tumor. So now another milestone is to acknowledge Marie and Pierre Curie for their discovery of radium, which actually was first used in as the first radioactive source for brachytherapy. She is a physicist that I have great admiration for, having lived in an era where it was really challenging for women to practice science, and yet received 2 Nobel Prizes, one in physics and one in chemistry. So, okay, this is another good picture. It looks funny right now, but these are from Melbourne, and a hospital from 1905, where nobody knew how bad radioactive sources were. Patients were given like small molds, like small plaques to hold in their hand to put on their faces if they had cancers. You probably know what would have happened after that, right? The tumor would fall off. Of course, their hands would also fall off. But nowadays we have we are in better times, and we use radioactivity in a very controlled manner. And that's how you use it in brachytherapy. Okay, so how do we use it? So here is a patient who has got a bit of remnant cancer after EBRT. What we want to do is we're going to guide a radioactive source in there, but we cannot put it directly in there. So we use something called applicator. So here is an applicator. The pointy part will go in the uterus, and the circular part, which is the ring, will go in the top part of the vagina, shown by that yellow schematic drawing that I have there. And brachytherapy, what we do is we put the source very close to the tumor, or probably inside tissue very close to the tumor. And then what happens is, this is how the image would look like after the tumor, after the applicator is put in. And then the patient goes for treatment. Think of the pillow as the patient. I cannot have a patient here. And then you have the applicator inside the patient, and then there are the radioactive sources inside this machine we call an afterloader. A very simple machine that will treat the patient. See how small that source that is inside the afterloader is, less than 5 millimeters, and yet so powerful in curing that cancer. So to treat these patients, we just mentioned here that we have applicators going into the patient. So here, what we're going to do is we're going to look at what applicators are best. So at the cross, we have a huge pantry, if you want to call it. So many applicators, and I've shown only 5 here, but each of these applicators come in so many different sizes and combinations. So we are one of the centers, I would say maybe the only center in Canada that has all these applicators, commercially available applicators, to treat these cancers. And I would like to thank the generosity of our donors who have helped us acquire some of these applicators. So now these applicators have to fit the anatomy, right? Shown here is an example of the tumor in the red dotted line. You put in an applicator called an intracavitary applicator. By the way, I have one sitting at my desk right now. So this is the size. If I put it, I'm not sure. So maybe it's about 30 centimeters long. So that is the size of an applicator. The blurred background is causing problems, but still you get an idea what it is. So it goes in the cavity. It's called an intracavitary applicator. And then the green shaded region is the dose that the patient's going to receive. See how well it covers the tumor or whatever has been contoured by the physician. But there are times, challenging times, where the tumor has got a lateral extend and an intracavitary applicator is not going to catch it. In that case, we add a needle to it. So that's what we do here. I have the applicator here. We have needles. So I can thread it through this. And that's how we treat the patient, and see how well you can expand that dose into the region you want the treatment to be done. This is called an intracavitary interstitial treatment. Interstitial means in tissue, so the needle goes in the tissue. So what is a workflow for brachytherapy? So the patient gets an MRI just before the brachytherapy treatment, a couple of days before, but definitely after the EBRT. The doctor will identify where the tumor is, or in his or her mind, they will think about what applicator to put in. The patient then goes into surgery in the OR, and then the applicators are put in. The patient then goes to have an MRI, and looking at the MRI, the physician will contour the draw out all the organs and the tumor. We make the plan on where the dose has to go. Usually we call it a pear-shaped distribution, usually for the cervix, and it does look like a pear, right? It's coming. I'll have to use that word later on in the talk. And then the patient goes for treatment. So there are 2 ways we can deliver this treatment at the cross using an afterloader. And I alluded to this in the first slide where I was talking about the schematic of the treatment pathway. One way is that the applicator is put in, the patient receives a fraction of radiation, stays with the applicator for 18 hours, and this happens in week 1. Applicator gets taken out, they come back the next week, and the same is repeated. High doses of radiation are given during each fraction, and that we call a high dose rate brachytherapy after loader. There is another way to give the radiation. There's only once that the applicator is put in, and small, tiny doses, doses are given every hour for a few minutes. So let's say like 10, 15 minutes of an hour. The patient can get up and walk around because the applicator is inside her, and and they are on the bed for about 58 hours. This is so like because the treatment is just like a pulse every few minutes of an hour, we call that pulsed dose rate brachytherapy. Okay, so now you must be thinking, oh, why put a patient through all this, right? It's so invasive, but there's concrete evidence that it is necessary. So if you look at this graph, of course, I'm a physicist, I need a graph. So here you can see in the blue are patients who received no brachytherapy, and in red are patients who received brachytherapy. And you see the difference. It's 12% higher overall survival for those who received brachytherapy at 4 years. So this is a major proof that it is good to have that brachytherapy boost after the external beam treatment. So with that, I have to acknowledge that it is not just a person or two that helps the patient through it. It's a huge group of personnel. There are the radiation oncologists who help with help the patient or look after the patient, dosimetrists who plan, therapists who deliver the treatments, medical physicists taking care of everything, the machines and the treatment part, imaging personnel, nurses, so many more people who are involved in this treatment pathway. I just clumped them in this green gear. And most important of them are our volunteers, our fantastic volunteers who help these patients through their treatment. So what is our goal? In the We Cross the Cancer endeavor, we are putting our patients first. So that is some overview of the treatment options. Now I'm going to go talk about my research. So before that, let's look at where globally we stand. You can see that we don't have much cervical cancer in North America. If you look at just all of the Americas, you will see that Canada appears at the bottom, and that's really good because the incidence of cancer in Canada is kind of like about 1,400 patients per year. So that's really small number. So what can we do? We can really aim at curing the cancer. So this is a sentence from the Director General of the World Health Organization, who says 1 woman dies of cervical cancer every 2 minutes. That's in the world, right? Each one is a tragedy, and we can prevent it. So if we could come up with something, it's just not for Canada, it's for the world. So WHO's global strategy is something called the 90-70-90 target for them, that by 2030, you can get onto the path to eliminate cervical cancer. So what they want to do is that our recommendation is that by 90% of the girls are vaccinated by 15 years. 70% of the women are screened by 35, and again at 45, and 90% of the women with cervical disease get good treatment. So our main aim is equitable treatment for everybody. So now let's look at Alberta. I've just highlighted in yellow the gynecological cancer or women's cancers, just specific to women, okay? And you can see that cervical cancer is not a small number. We in Alberta contribute to about 14% of the national statistics that's reported. So what does that mean? It's time for action. So what do we do from now? Like, why now, and why? What are we going to do here? So in Canada, there is an initiative that you can see that shown in this boxes is the cervical cancer statistics, and it's on a declining path. Really good, right? So the aim is that by 2040, we can totally eliminate cervical cancer in Canada. And how are we going to achieve this? Through vaccination or immunization, better screening, and better follow-up. And a more important thing is equitable access to everybody to this healthcare. But then, is there any other way we can accelerate this decline to reach this 2040 goal? And that's where research comes in. Okay, and I would like to again thank Vickery, the Louis Hall Hospital, the AWHF, and Alberta Cancer Foundation, who have supported our gynecological cancer research at the Cross. Okay, so some of the, we don't have time to talk about a lot, but then I'm going to talk about some of our endeavors aimed at personalizing cervical cancer treatments. And we will look at these, what each of these boxes allude to. So first of all, the first stepping stone, like somewhere in the early, late 2000s, what happened was we were doing CT-based planning. So you know that when you use a CT scan, you cannot really see all the tissues around very clearly. And we did mention that MRI is the best for this kind of treatment. Right? Look at that, how well you can see all the tissues around it. So somewhere in 2009, there was a national or an international study initiated. It was in 2000, like mid 2000, that this was initiated. And in 2009, Cross decided to join the study. And thanks to the Cecilia Johnston Endowment, it supported our first step into joining, to becoming a participant of this EMBRACE trial. It was a huge success, and we progressed to be part of the EMBRACE 2 trial, the part 2 of that study, which just closed in December of 2021. And we were one of the leading, or I would say the leading participant in North America. And as of now, MRI planning is standard of care at the Cross Cancer Institute, and it has been for a while since we joined this study. Again, thanks to all the funding that we received. So now coming to this, so one of the research that we do is starting from the cellular level, and that's where we should start, right? For curing cancer, we should know how the cells are going to respond. And one of the earliest slides showed that a lot of these cancer cells are squamous cell, and then adenocarcinoma, and or some other cells. So basically squamous or adenocarcinoma. But what happens is, though they are different cell types, the treatment is similar, but you can see from this graph how different the outcomes are. Shown in blue is the squamous cell carcinoma survival patients, and red is the adenocarcinoma cell line. And you know that adenocarcinoma, you can see from that it's not as good as that for the squamous cell carcinoma. So we wanted to look at why this is happening. So the doses given to both these cancers are the same. And the delivery method is also the same. So we want to check what are the parameters that goes into the calculation of the dose that could be different. So for this, with funding, we did some biological modeling. There are so many things going on here, but basically what we did was we took squamous cell and adenocarcinoma cell lines, irradiated them both on the high dose rate and the pulse dose rate brachytherapy machines. You can see here, the cells are being irradiated by the source from the afterloader, and this is where the source would move, and very close to the source, you will have complete killing of the cells, and further away, some of the cells are going to survive. So shown here is a plate with all the cells there, and you can see as the dose is increased, more and more cell killing will happen, right? And our study showed, we looked at what the survival fraction was, and that's the graph. I have to have a graph again. So here, what we found, the results of the study showed that, yeah, there is a difference. And it really reinforced our hypothesis that squamous cell carcinoma and adenocarcinoma are going to respond differently. And the doses that you deliver from the HDR and the PDR are going to be having a different kind of effect. So right now, whenever we do these kinds of studies, first we do it on the cells. We call it in vitro, and that's what we did. The next is to do some animal modeling, which would be in mice, so in vivo. And then after that, we will take real patient cells and try things in the clinic. So that's what we did in our cellular study. But then we wanted to look at how it's going to make life better, right? So now our goal is to look at which is better, what doses should we give, how are the cells going to respond. After the in vivo study, maybe look at clinical evidence to come to a conclusion. So now we are going to prepare. Am I running out of time?
No, you're good.
Okay,
Yep.
Okay, thank you.
Yep.
So how do we prepare? So another thing we wanted to help is the physicians, right? So at when we do pre-brachy MRI, that's after the doctors will look at it, and we have a variety of applicators. They have to choose which one will be best for the treatment. They will put that in the patient, and the patient gets treated. But this is after a lot of speculation to guide the strategy. And because you can see, look how much deformed the anatomy becomes with the application of these with the insertion of these applicators. So sometimes it's not possible for them, even with their like tremendous experience, to exactly predict that deformation. So we might not be able to choose the right applicator. And then this is not something like you can go in and do everything all over again, right? So we thought that maybe predictive modeling using some kind of artificial intelligence will be the way to go. And I like this quote very much. People do say that, oh, artificial intelligence is going to replace doctors. But no, this quote from Dr. Bell is really good. It's not going to replace doctors, but they're going to augment them, enabling physicians to make better medicine, practice better medicine with greater accuracy and increased efficiency. So then, a little basic of what artificial intelligence is. It's a simulation of our human intelligence by some machine. It'll learn, it'll plan, it'll reason with itself, and finally solve the problem. So our input in here for the simple logic is a lot of mice, a lot of dogs, and a lot of cat. What the system is going to do is going to train itself. So there's going to be some input from us. It's going to train itself, look at the features, patterns in this group. It's a crowded group, right? And once it learns, it will give an output where it's going to separate the mice, the cats, and the dog. This is basically what artificial intelligence is going to do. So in our case, how are we going to use it? We have a lot of images of patients who were treated with brachytherapy. So we'll have images before the applicator is put, and we'll have images after the applicator is put in. So we have paired images, right? We identified the different structures, like the uterus mainly. And what we did after that was put this as an input into the training module. And what did it predict? It was very successful in predicting how the uterus is going to change. So now, after the model has been developed, it is going to tell us, okay, if this is the shape of your uterus before the applicator, this is how it's going to be after the applicator is put in. So shown here is a model where you can see the uterus before the applicator is put in. Shown in red is where, for this particular patient, the tumor ended up. That is the truth, right? Ground truth. And the model that we developed said it will be somewhere in that green region, or it's going to be that green region. So this is really good. And the similarity index what we mean is that success rate is about 90% here. So you might think, oh, is 90% really good? But in such a challenging situation, look at this, what went into the training. There's so much deformation happening. This shape to this shape, it's really challenging. So 90% is pretty good. So what is the significance of this study? It's going to help personalize cervical cancer treatment. How? It's going to be more effective, helping the doctors, or it holds the promise for better, faster, streamlined clinical decision making, and that too prior to the brachytherapy is done. And we hope that it will end up with better outcomes for our patients. Now, to another, switching gears, we said that when the patients have to be treated, you have an image taken and the doctors have to go and contour each of these organs, right? Because there is a lot of normal tissue around the organs that are being treated, we need to be very precise in these segmentations. When the standard practice these days by the doctors is to spend about 2 to 3 hours manually contouring all these structures, just extremely laborious and also very, very time consuming, right? So but there are options right now, like from researchers as well as some commercial products, which can auto contour these or like automatically contour these for you. And the doctors just need to finesse it before treatment or then before planning. But unfortunately, it's very difficult to do it for gynecological cancers. And also most of those are done on CT scans, which is easy because we have a different algorithm which works and it's very easy. But we are treating our patients using MRI images, and there's not much progress in that region. And that's where our next project comes in. We are trying to use machine learning to do 3D multi-organ automatic segmentation of these organs. So we have only started on this project, so I don't have much results to show you, but this is in progress. And we hope that this will really, really help improve the contouring consistency between the doctors, reduce overall manual contouring times, right? And what does that do? It'll speed the time towards the delivery of brachytherapy. So now, okay, so now we looked at contouring. What about delivery, right? When you're delivering, we just said, I put a different shapes of pear here. Every woman is different. The cervix is different, the anatomy is different. So we said we have a whole shelf full of applicators, but still we often find that, this does not fit this patient. Hope we had a better applicator that would fit the patient. So one workaround for that has been investigated is the use of 3D printing. So we take the patient, because we know from the previous project how the anatomy is going to change, we can probably come up with custom applicators for the tumor size that the patient has right now. Right? And how does that going to help? It is going to include both patient anatomy and the tumor geometry, and we will make these custom applicators. Remember the one that we looked at, that ring applicator? It's going to give us better dosimetry. Better dosimetry means better dose distribution, higher dose to the target, while really lowering the dose to the normal tissue around it. And ultimately, we're going to have improved outcomes with this personalized treatment. So basically, I've touched on a lot of these activities that can help improve the treatment. But then what's going to happen for the future, right? So this is a graph. It's from 2013. But still, it shows the decline of the use of brachytherapy over time. It has improved now with more and more robust studies showing that brachytherapy is important in the treatment pathway. So you can also look at this survey here. This was a survey from a Canadian group. Just look at the ones at the bottom, which is pertaining to gynecological treatments. This was a survey of the residents. Residents means they are doctors. they are training to be radiation oncologists. So it's like a specialty in their medical career. So the green shows that these residents had limited or no competence or no past exposure, which is unfortunate. So what we want is that for these residents to have better hands-on training. And brachytherapy is about hands-on procedure. It will combine clinical knowledge, and also it's not an expertise that you develop overnight. It's just it's developed incrementally. You get it through each procedure that you perform. But if you end up in a hospital as a resident where you don't have these opportunities, you cannot get this. So what we are aiming for is training the next generation. And in this case comes the effect. So you don't want the situation to happen, right? Such a situation will have significant implications for training our oncology resident. And this is where virtual reality helps out. So virtual reality has been shown to be effective in lots of areas in healthcare, and it can shown to help accelerate a learner's skills in performing procedures, especially in surgical training curricula. So here is a pie chart. Just look at the part in green. So gray. This was done. This was taken before this is surveyed from the residents before they used a virtual reality tool of performing a procedure, and the one on the right is after they played with that game or the virtual reality game. See the performance, their confidence increased 50%. But of course, this is not the same as doing the procedure by hand, but really helps improve the confidence of the learner. So now, what did we do? We developed, this is our first prototype, and of course, first iteration, it's lots of improvements to be done, but this first prototype can simulate the procedure of putting in the applicators in the patient. And as great, we have received a lot of accolades for this from our radiation oncology community. We will be presenting this at the Vickery Research Day next week. Hope you can join. And this will help the trainees understand the process on how to do it. And then, like I said, it's not the same as doing it on a patient, but at least it helps them be ready for that procedure, or like in simple terms that we are informally, how do we say that? Not go in blind, right? So this immersive interactive tool can help them prepare for their career in brachytherapy. And here what we're doing is several steps. It'll need an assessment. We need some outcomes, how to deploy this, and finally come up with a good design with a lot of cases in it so that the residents get an idea of the different scenarios they are going to work with. So it is, again, not a person. It's a huge brachytherapy team here. And here are some of my great colleagues that I work with at the Cross Cancer Institute, and some of our great collaborators who are experimental biologists, computer scientists, radiologists, and the stars of the show are our students. So they really help us achieve our goals, because, we are all clinical people. We don't have the time to, we do have to find time, but during our clinical work, it's very difficult, and they do take our projects far, far, far ahead. So I have to thank them all. And so what do we say? We say that personal treatment, all these personalized treatments with all these different parts to it, is going to end up with better cervical cancer patient outcomes. And so now the question is, how can you help? I don't want to put any words here or tell you what to do, but there are several ways people can help us. A way you could do it is you could volunteer. Just just volunteer in several of the activities here, or just a simple word of appreciation is great, right? Like it boosts our interest in doing the work we do. Or you can fund some of the research or support some of the programs that happens at the cross. And another way you could do it is if you have students at home who are working at the or studying at the university, or friends who have kids who are studying at the university, we're always looking for more help, to help with the research so they could participate as summer students or probably do some projects with us. That will also help us in a huge way. So that's the end of my talk, and thank you everyone, and thank you for the different organizations that are supporting this talk. Thanks.
Thank you so much. That was really informative and really, really interesting. So thank you for agreeing to speak with us this evening. My name is Rhiannon Adams. My pronouns are she and her, and I am a member of the Louisville Hospital Women's Society and also a chair of the Supporter Experience Committee. And I am going to be responsible for the Q&A this evening. So if you have questions, you can put them in the Q&A box. That's where I'm going to start. You can also put them in the chat box if the Q&A box isn't working for you, and I will review both of those, but Q&A is preferred. So without further ado, I'm going to start looking at that. You can stop sharing your screen if you want to.
I'm trying to.
Oh.
I am trying to, but
okay. Well, you may want to leave it up though if people have questions and you want to.
Oh, I can always bring it up, right?
Okay.
Like, yeah, okay.
Yeah. Sounds good. All right. So the first question is, do you believe that personalized radiation therapy might accelerate the treatment timeline? Personalized radiation therapy, or is that something sort of a bit outside?
No, I don't understand what is meant by accelerating the treatment timeline. Can you repeat the question?
Yeah. So it says, do you believe that personalized radiation therapy might accelerate the treatment timeline? Maybe that means that they are treated faster, or
it's in some areas, yes. Like, I told you, like the contouring of these organs by the doctors, that really will help with the ability to start the treatments faster, because if you can have an contouring software, instead of using 2 hours, you can probably do it in like 5 minutes, and the doctors actually do it in like maybe 2 or 3 maybe 15 minutes to adjust the contours. Of course, a computer doing it and an experienced person doing it is way different, right? So maybe another 10, 15 minutes. So the 2 hours is now reduced to a 15 minutes thing. So the patient does not have to wait around to get the treatment. You can reach that faster. Predicting what applicator to use, that's a great thing. It's not going to save your time, but it's going to. So for me as a person, I would rather get a better treatment than a faster treatment. Don't you agree? Because you would want a precise, accurate treatment. You don't want to come back with cancer again. So it's better to get a better treatment. So I would wait as much as I have to get that good, precise treatment. Absolutely. So, but all these techniques would definitely help us reach that 2040 goal, though.
Yeah. And the second question was, do you see research moving into this research in particular, moving into other provinces across the country?
Oh, yes. I'm pretty sure, somebody in the world is also doing similar research, right? Research is really tough. You come to an end and then, there's somebody who's already done it. It is definitely, yeah. So we work with Calgary a lot. So we got a recent funding from Alberta Cancer Foundation. It's a huge amount that we received, which we are going to collaborate with Calgary. And of course, each of us, both Calgary and us, we have other collaborators like internationally. So this is just not going to be at the cross. Though I say cross, it's us leading it locally here, but we do have collaborations with elsewhere. Of course, yes, yeah, for sure.
I have a question, so I'm going to jump in. I find that artificial intelligence is being used in so many different industries, and especially health related things as well. How did that sort of come about for you, and who are you working with? Or do you have like AI expertise on your team?
Yes, exactly. Yes, I do. So my work is in physics, and as I said, I like to do something like in artificial intelligence, I would need the whole day, which I don't have, right? So what we do is we collaborate with computing science. We have the internal expertise, but that's where our students come into play. So the students are working 24, I won't say 24/7, but at least a few hours a day. So we just guide them. They come up with the product, and we just guide them on what to do. So I work closely with Dr. Pierre Blanger. He's an expert in AI, and Dr. Kumaradevan, Punita Kumar, who works in radiology. They are experts in this technology, and we have students locally and as well as in computing science who help us develop this.
That's fantastic. It really is the future of so many industries, of getting that information and getting some results out of it that you can then use to apply and help other people. I think it's fantastic. We do have a question about the Wickery Research Day, and I'm glad that someone did ask about it, because I wanted to ask about it. Can you talk a bit more about Research Day next week and where it is and what's going on?
So I believe the last day for registering is on the 30th. If you just type in Wickery Research Day 2022, it'll come in, and there is an option to register there. Somebody has put it on the chat. Yolanda, thank you. And you can go there and register. 30th 4 p.m. is the last day. And the program is also available there. And I'm really excited about that.
So it's for those.
It's virtual. It's virtual.
Oh,
so you can
virtual.
sit at home and do it and join it. Yeah. So that's fantastic too. Yeah.
Yeah. I was going to ask, because I know I went pre-COVID, and there was a presentation and there were posters. So how does that work? Are there virtual presentations?
That will be virtual presentations. Yeah. So the people are given, the presenters are given. So oral will be like an oral. They are given a slot, and then for the posters also, the presenters are given a small timeline where they will present their poster, and they're judged on it. Yeah.
Cool. Wondering about the timeline on some of your projects. I know you did mention some of the timelines, but sort of how far out do you see this getting to people? And if I got diagnosed, in a year from now, is this something that would be able to be used?
Yes, definitely. So the cellular part is done. That's going to take time, right? It's not like an artificial intelligence project or a physics project. Anything with biology, like with cells, or it takes a while. And it takes time to get a result. So that is a progressing one. So now we have just started on the mice. It took us maybe 2.5 years to finish off our cell experiments. Now we are starting with the mice experiments. So it'll be another 2-3 years before we get to. But on the side, we are also getting, we're coming up with a protocol where we can get cells from patients so that we can develop our own cell line to do this. It's very difficult to go into the market to buy these cell lines, because they have been there for a long time. They have evolved, and we are trying to believe in them, but there could be differences, but it's not the same as having our own cell line, right? But any other things that, like the artificial intelligence project is completed. The student Shrimanti, she's almost finishing up her studies in PhD, and this is her thesis. So we are taking it forward and trying to apply it into a broader spectrum, right? You don't stop with what you have, you're going to apply it into a broader spectrum. So those are all out there. Yeah.
That's fantastic. So you did mention the funding that you're getting and the work that you're doing in relation to sort of the funding that you're getting. How do you think that that's made a difference to?
Oh, you know what? I cannot. I'll just put it this simple way. It wouldn't have taken off. This research wouldn't have taken off, right? So the cell biology research could only take off with funding. Though we started on it with the funding, it just took off because the ingredients we need for doing this research does not come free. Right? They are pretty expensive, and really support for the students to do the research. And more than that, that funding really helped do the research. And the artificial intelligence too. We need to support this. We need to feed our students too, but a major portion of it goes into building that project. Right? So yeah, of course.
Yeah, and we're happy. Obviously, we're excited to have you here to talk about the research that you've done. I think we've made it through all of the questions that we've had. Was there anything else that you wanted to talk about or to touch on before we wrap things up?
No, I would really like to thank everyone here for joining in, and hope that you don't have to come to the cross, but right. But I will also say don't feel dejected if you have to. It's a fantastic crowd here and a lot of experts. Our doctors are great. Our support staff is also fantastic. So yeah, and the research that's happening here is great. I would really like people to support the research more, know about it, support it more in whatever way you can.
Yeah. Well, thank you so much for joining us and giving us such an informative discussion and answering our questions this evening. I am going to share my screen briefly, if I can. We'll see if I do this correctly. Someone I'm sure will tell me if it doesn't. Maybe not. All right. So I am again going to take the opportunity to thank you, Dr. Menon, for joining us this evening, and to thank everyone who has joined us today on this What the Health event. It really is an amazing community, and we love giving these talks to you, and we love seeing you attend and participate and learn. I learned a lot this evening for sure. If you would like to continue to support the Women's Society, we would love for you to consider becoming an active member. And becoming an active donor, monthly donor is what we typically do here. But then you can also come in and volunteer with us and support us in that way, if that's something that's of interest to you. Now is the perfect time to sign up to become a supporter, because if you do that, you will be entered into a draw to win this exclusive, I'm sort of pointing to it, but this exclusive on the screen, Hope Box. And if you can use your mobile device, you can scan that QR code on the screen and it'll take you directly to our website, which is LHH Women's Society. So that's for Lowell School Hospital Women's Society.com, where you can sign up or learn more about what the Women's Society mission is and what we've accomplished so far. So again, a very special thank you to all of those who donated when you registered registered today for this What the Health talk, and also to the individuals and the businesses who support us monthly, because we wouldn't be able to support wonderful research like you've just heard about tonight without you. Last but definitely not least, a huge thank you, as always, to Alberta Blue Cross for supporting our What the Health talks. Don't forget, a feedback survey will be sent to you pretty shortly, and if you fill it in, you'll be entered to win a $25 gift card courtesy of our friends at Alberta Blue Cross. The winner will be contacted directly by a representative. It won't be a joke. Sometimes people think that it's not possible. It could have been them, but it can be you. So if someone calls you and tells you you won, believe them. Our next Mind and Body Talks will be held on November the 24th, 2022, and we're going to talk about breast reconstruction. I think that was all I had to touch on this evening. Thank you for attending, and we hope to see you next month. Have a wonderful evening.
Thank you so much. Bye-bye.